Hello there, my name is Kamran Bhopal and I'm a registrar in urology, and I've recently gained an ST3 urology national training number. Starting off with testicular cancer. So in testicular cancer, you can look at my video how you would take a history of testicular cancer. That is one part of it, and then you start on to answering the questions that they may ask. So the first question they might ask you after examination is, what investigations would you organize? And you would say the definitive investigation is same-day ultrasound testes with almost 100% sensitivity. Would also request some bloods, including full blood count, renal function, clotting, as well as tumor markers including AFP, beta-HCG, and LDH. I would also ask for a viral screen including Hep B, C, and HIV, and a hormone profile looking for testosterone, LH, FSH, and prolactin. I can consider doing a same-day chest x-ray if there's any signs of widespread malignancy, or a CT scan of the chest if readily available. Otherwise, staging scans include a CT chest, abdomen, pelvis with contrast, plus minus a bone scan, plus minus a CT brain or an MRI of the brain in select cases. I would also request a semen analysis. So these are the different investigations that are in testicular cancer. I've not missed anything. Not some books write some books write some. So I've just comprehensively spoken all of the things that can be included in an investigation question. How you would investigate testicular cancer. So then they can ask you what will be your next steps. It's more the understanding of the environment. I would ensure that the patient's relatives present and very sensitively break the bad news in the presence of a cancer specialist, nurse present, and start the consent process if he has taken the news nicely, but move forward according to the things the way you do them in the NHS, and you would be safe. Then comes the consent process, so you should be able to consent for a radical inguinal orchidectomy, and they would probably first ask what would you offer the surgery. So important to say inguinal orchidectomy, not a simple orchidectomy which is done via the scrotum. Any other therapy that you would offer to the patient is, you can consider testicular prosthesis. We can now sometimes do it at the same time, and also sperm banking and fertility assessment can be offered to the patient. But this should not delay his radical inguinal orchidectomy. This just needs to be done, the sperm banking and everything, before any chemotherapy that needs to be given. So it can essentially be done after the surgery from the contralateral testes, but before chemotherapy. So that's important. When would you consider contralateral testicular biopsy? So there's 3, according to EAU guidelines, if the age is less than 40, if the testicular volume is less than 12 mils of the contralateral side, and if there's a history of cryptorchidism or reduced spermatogenesis. So I've already mentioned all of the investigations in the initial investigation bit, but if they ask, okay, what further investigations would you do, and they stopped you initially on just the tumor markers, bloods, and ultrasound, and then they want to know about the staging scans and what are your next steps. So in that case, you'd say I would do a CT chest and pelvis with contrast as a staging measure. MRI can be used in select cases who are allergic to contrast, and PET scans are usually done to look for residual disease after, for example, a chemotherapy in seminomas. And then you say tumor marker kinetics and histopathology of the testes, and discuss it in the MDD and move forward accordingly. Another important question is the classification of testicular tumors. It's quite straightforward, although there's different classifications present. The one that I used and found the most comprehensive was the WHO classification, and that's also in the FRCS Viva book. And the way you classify testicular tumors is that there are germ cell tumors, then you've got sex cord stromal tumors, you've got mixed tumors, and then you've got other types. So your germ cell tumors are seminomas and non-seminomatous germ cell tumors. Seminomas are further divided into classic seminomas, spermatocytic seminomas, and anaplastic seminomas. And then you've got your non-seminomatous germ cell tumors, which include all of your teratomas, embryonal carcinoma, teratocarcinoma, yolk sac tumors, and choriocarcinoma. Then moving on to sex cord stromal tumors, you've got your Leydig cell tumors and Sertoli cell tumors. In WHO classification, they also say granulosa granulosa cell tumors, unclassified tumors, and mixed sex cord stromal tumors. Then you've got the mixed types, which is mixed germ cell and sex cord stromal tumors. And then you've got other tumors such as lymphoma, adenocarcinoma of the rete testes, and metastatic disease. So this is an important one for you to remember. And then what are the factors to consider for adjuvant treatment? So there's some characteristics which will make you a bit worried, so you would want more treatment. Although, this is an MDT discussion, but you need to have a baseline on it. So for seminomas, if there is rete testes invasion, or if the tumor size is greater than 4 centimeter, then we should consider it. And then non-seminomatous lesion, if there is lymphatic and microvascular invasion, if the proliferation rate is greater than 70%, and if the embryonal content is greater than 50%. So these are the different questions that they can ask. There's some additional questions as well that I've written, and I think they might be important because they do start with something simple. So they might ask you, okay, what is staging? And at the moment sometimes you can't come up with a very good definition, but the way I've defined it is staging is the extent of disease based on clinical, radiological, and histological measures, which helps us with understanding the prognosis of the disease and suitability of systemic treatment. So it's a very simple definition, but it covers the whole aspect of staging and how it helps. Then the treatment options, if the histology comes out as seminoma or specifically grade 1 seminoma. The 3 options that are available is number 1, active surveillance with annual CT chest, abdomen, pelvis with contrast, and 3 monthly tumor markers. And this can tail off after 2 years, and this needs a 10-year follow-up in total. Then you can have chemotherapy as a single dose, and that is usually carboplatin. And also you can have radiotherapy in the form of a hockey stick or dog leg pattern, and that is usually given as a 20 gray dose over 2 weeks in 10 fractions. You don't have to say this, but if you know it, and say it, it's pretty impressive for the interviewers. Now, chemotherapy and radiotherapy, this is extra information. Chemotherapy and radiotherapy reduces the risk equally. So if you do active surveillance alone, the risk of recurrence is about 16%, whereas if you do chemotherapy or radiotherapy, both outcomes are equal, so it reduces to 4%. What is intratubular germ cell neoplasia, also known as intraepithelial neoplasia? Important one to remember. I'm not sure if they've asked this recently, but this is something important to know. So intratubular germ cell neoplasia is a malignant pre-invasive testicular germ cell lesion, also known as carcinoma in situ. It is a precursor for all germ cell tumor except spermatocytic seminoma, and it has 50% chance to progress to germ cell tumors over 5 years and 70% probability of developing cancer at 7 years. So important to remember. I will stop the video here. All the best. See you next time.